My name is Kathesha Giovanni. I'm one of the board members for Gaspin, and I have the pleasure to introduce our next speaker. Bailey is an experienced registered dietitian specializing in pediatric nutrition. She has extensive knowledge in the areas of failure to thrive, feeding issues, obesity, celiac disease, and our other gastrointestinal diseases, food allergies, as well as nutrition support. Please join me in welcoming Bailey Cope.
Great. Good afternoon. Thank you to Gaspin for having me here today. And hopefully to teach y'all how many of y'all know about blended diets or use them in your practice? Okay, just a few. So hopefully by the end of today's talk, y'all will feel more comfortable in implementing them in practice. So let's see, where's the clicker? Okay, and now the arrow should just work. Great. Okay, so I have a few disclosures. I'm on the Speakers Bureau for Nutrition North America, Mead Johnson, and then the Medical Advisory Board for the FBIS Foundation, nutritionforkids.com, and Mission Mighty Me. But none of these should pose any conflict for today's presentation. So today's learning objectives are going to be to describe the history and evolution of blenderized tube feeding as a nutritional therapy, to identify clinical and personal reasons for choosing blenderized tube feedings over commercial formula products, to discuss appropriate methods for the safe preparation and administration of blenderized enteral nutrition, and outline the steps involved in creating a nutritionally balanced homemade blenderized tube feeding formula. So what are blenderized tube feeds? So I'll start, you're gonna see these referred to in a few different ways that are interchangeable. So our motility, our neurogastro doctor refers to them as puree by G-tube diets. So in our charts, PBGT, blenderized formula, homemade blended formula, and home brews. But they are basically a blend of food and liquid provided through a feeding tube. They can be sole source or supplementary to PO intake. So if we look at how far back blenderized tube feeds go, we can trace them back to the Egyptians. They provided them rectally. You can see with this fun little tool there. Then in the 12th century, we were able to feed via tube into the upper GI tract. 1793, we were able to feed into the stomach using a catheter and syringe, but it wasn't very successful. So by the 20th century, we had materials to administer these feeds directly into the upper GI tract. And in the mid-1900s, NG feeding was now a viable mode of delivery. So commercial formulas, this is when they started being developed. By the 1960s and 1970s, commercial formulas started to replace blenderized tube feeds. A lot of reasons for that. They had a standard nutrient composition, they were easier, lower risk for contamination, but we saw clinical outcomes worsened with this. And then starting around 2010 is when we started noticing the resurgence of blenderized feeds. However, even today, a lot of healthcare providers are reluctant to use them. I will say I have been using blenderized feeds since probably 2003. So since I started practicing here at Children's Healthcare of Atlanta, and then now mainly at my peds practice, so with GI Care for Kids. So we've used them for quite a long time and have seen the difference that they make for families and our patients. So why the resurgence? There's a lot of different clinical reasons, as well as a lot of personal reasons why someone would choose this over a commercially made formula. Number one, we see improved feeding tolerance. So there have been, a decent number of studies in recent years to support this. There was a review in multiple databases by Smiths that found reduced nausea, vomiting, diarrhea, gagging, reflux, constipation, abdominal pain, and improved volume tolerance. Two studies in 2011 and 2016 found 73% of kids had over a 50% reduction in retching and gagging on blenderized tube feeds. And then Batsitz et al. In 2020 found 95% of kids had a reduction in gagging, retching, vomiting, and other symptoms of dysphagia or aspiration. There was a study in 2019 showing a reduction in diarrhea of critically ill adult patients on blenderized tube feeds. And the reasons for improvement, a higher viscosity is one, leading to slower gastric emptying. They're heavier, so just gravity is going to help keep it down. So our kids that are vomiting, retching, it tends to make a total 180 of the patient. The higher fiber content of blenderized tube feeds, more physiological motility due to the chyme stimulating regular hormonal response. So for all of these reasons, just from experience, there is a night and day difference in these patients when we go from formula to blenderized feeds. The second reason would be improved growth. So studies show improved weight and height Z-scores on blenderized tube feeds with close dietitian follow-up, because these do, and I'll talk about that later, have to be monitored a little bit closer. The Olay Foundation survey found that 90% of children and 85% of adults reported no weight loss, compared to 59% of children and 52% of adults reporting no weight loss on commercial formulas. So sometimes that's something that dietitians say they're not comfortable with. They're worried about growth, and that's not supported. So kids do great on blenderized feeds as far as growth. Number 3, an increased interest in PO feeding. So a 2011 study found that 57% of the children in their study had increased PO intake on blenderized tube feeds. And the reason for the increased interest, the decreased GI symptoms, as well as they're getting a variety of flavors. So when they burp up the formula, they're not just getting vanilla or chocolate or unflavored. They're getting a good variety, which helps pique their interest. There's also decreased hospitalizations and reduction in healthcare costs. So a study in 2019 showed 53% less admissions, including 67% fewer respiratory illness admits and 43% less ED visits. And then another review showed reduced infectious disease complications, greater weight gain, and decreased number and length of hospital admits. And then last but not least, the diversity in the microbiome. So whole food diets with less processed ingredients that include a good variety are going to lead to more diversity in microbiome and better health outcomes. So if we talk about personal reasons, there are social reasons that families would choose this. Participation, so the child or I know y'all are not all pediatrics, I'm used to saying kids, so adults too. But they can participate in family meal times, as well as food preparation. They have the freedom to choose foods to include and foods to avoid in blends. So I have used homemade blends and done like a FODMAP type blend that has, in these cases, significantly helped these patients with GI symptoms as well. Parents want to nurture versus just opening up a can of formula. They have a more sense of control in a less than ideal situation. Most of these patients would choose not to need a feeding tube. But what they put in that tube, they can control. That's one thing that they can control in the situation. And then from a financial standpoint, If formula is not covered by insurance, then it's going to most likely be significantly less expensive to make your own. In pediatrics, tube feeding formulas are covered to the age of 21. So most of the time, that's not as much of an issue for us. But definitely in the adult world, I can see where that would make a difference. And then when kids are aging out, we end up having to switch a lot of patients over at that point just for the financial reasons. But these are some direct quotes from patients that I have worked with that I think are important to recognize. So, for example, I want all of my children to eat at the table together and everyone to eat the same meal as a family. I can adjust it if she's getting constipated. The next blend, I can increase the fiber, use more juice, or switch to flax oil, so I've got control. I changed to blended feeding when it dawned on me one day that my son had not had a vegetable or a fruit in 5 years. My child is the most vulnerable of us all, yet I'm feeding the most processed item to him, and the same thing every day for years. So those are all very real concerns and a big reason why we're seeing this resurgence. So who is a good candidate for blenderized tube feed? So from the Aspen practice recommendations, this quote, before initiating blenderized tube feeds, consider the patient's entire clinical picture, including patient-related factors, so psychosocial, socioeconomic, and clinical, their enteral access device, nutrition needs and dietary requirements, dietary preferences, access to resources and food, tolerance, food safety issues, and costs. So there are a lot of things to consider. I work only in outpatient, so when I'm meeting with a family that has come in on their own to discuss blenderized tube feeds, or if they've been referred because of their GI issues to try a blenderized tube feed, not everybody is a good candidate. So you have to be able to identify and see whether or not it's appropriate. So family dynamics, the first thing to consider, what is their home environment like? Do they have access to a good blender? Do they have access to refrigeration, sanitary conditions, even like freezer if they're going to blend in advance? Family support, cost, and history of compliance or non-compliance. If I see in the chart this is a family that doesn't come to their appointments on a regular basis, or they're not compliant with the medical team recommendations, if this is a single mom that is already struggling, or a two-parent working household that's already struggling with all the other medical care that they're providing, then homemade blended foods as well as commercial blended foods sometimes may not be the best fit for them. Medical support. Do they have access to a dietitian that's familiar with blenderized tube feeds? There's also patient aspects. So they need a healthy, established G-tube site. It is preferable to be going through a G-tube. However, they can go through a J-tube. I would say a commercially blended formula is going to be the best option. Home blended formulas can be tough to get through a J-tube. So, but again, it goes back to the blender. There are some blender companies will provide the blenders at a significantly reduced cost if they have a letter of medical necessity showing that it's going to be used for medical reasons. It is preferable to have a 14 French or larger G-tube, but smaller can work. So some commercially available products do say that their product can go through as small as a 6 to 8 French. So you would just go by the manufacturer's recommendations. In peds, I've definitely used a 10 to 12 French, but you just have to be, again, really careful and make sure the type of blender they have. Otherwise, you're going to run the risk of clogging. Medically stable for the transition. So I always make sure that their growth, whatever the goals are. So in an older kid, if we're just wanting them to maintain where they are, If it's a younger child and we're wanting to see good growth, sometimes even weight loss if they were previously overfed. So I like to have calories established before I transition them over to a blenderized product. Even when we keep the calories the same, sometimes we see differences in growth when we go from formula to blenderized. So it's a whole lot easier to tweak at that 1 month follow-up if I had a starting place. Preferably on bolus feeds using a 60 ml syringe or some of the like Boley links. Those work well. But again, they can go on a pump. The higher viscosity feeds, which I will go through some of the different options that are available, will not go through a pump. So they would have to be, depending on the product, on bolus feeds at that point. And then volume tolerance as well. So this is a really good comparison to show the benefits and risks of home blenderized versus commercially available blended diets. And you can see, that both commercial and home blenderized tube feeding products are going to show an improved GI tolerance, increased oral intake, increased caregiver or patient satisfaction. But then when we get into cost, that's where it differs whether or not insurance is covering or not. As far as the risks, so there are more risks associated with your homemade blenderized feeds. So your caregiver stress and burnout due to the, thank you, due to the preparation. For that reason, most of the families that do make their own will blend in advance and then freeze. So tube clogging. So there's a highly variable nature of viscosity when you're talking about homemade blended feed. So again, it goes back to you have to have a really good blender. So for the microbial contamination, food safety, good food safety practices is important as well. And then there's variability in, so again, if the family is non-compliant, they're not going to take the recipe that you've provided them with and follow it, then that's where the risk of growth comes in. So making sure that they're a good candidate and they're a family that typically follows what they're supposed to do is important. Other things to consider would be the hang time. So when it's homemade, you would not want it out longer than 2 hours. A lot of the commercially available products can go up to 12 hours. So again, you'll just follow the manufacturer's recommendations for that. The method of feeding, need for healthcare provider involvement, both are suitable for inpatient. Most hospitals, I think, will have their own policy on this. Back when I worked at CHOA, patients could actually bring in their own blends and the kitchen would also make them, but I know things have changed. I don't think that is still the case now. And then preparation time is going to be increased for homemade. The travel ability is more difficult. Most of the families I work with, they will take their blender with them or they'll pack a cooler. And then we do use commercially available blended formulas for a backup for those families as well. So they can do both. So there we go. Okay. So if we talk about the different options, there are a lot of commercially available blended products on the market. So it's not biased. I have included every brand that there is. They all have pros and cons. The first one, functional formularies, it's plant-based. The calories per mil is going to vary, and they come in 12-ounce pouches. They have pediatric and adult products. So Nourish is their pediatric line. They have a peptide version as well. In pediatrics, we will often use the peptide version, even if the patient doesn't need a peptide formula, because the calories are higher. It's 520 per bag versus 400. They also have Liquid Hope and Liquid Hope Peptide, and then some keto specialty formulas. Kate Farms also has a blended formula that's pea protein based. It is just pediatric. 1 calorie per meal. They come in little 8-ounce pouches. They look like the baby food pouches. And there are 3 different flavors. So this one we may choose, like if the child is eating by mouth, because they can eat from the pouch, and then we can pull up the remainder in a 60 ml syringe, or we can use the Bowlink attachment and push it right into the G tube after. So we can do a really good blend of PO and G tube. Nestle also has complete organic blends that have a plant-based as well as a chicken-based option. They come in 10-ounce pouches, and they have your pediatric and your adult. They're a little bit higher calories per meal. There's also Real Food Blends that now Nutricia owns. But they have 6 different meals. So they have like eggs, oats, and oranges, or like beef, spinach, and rice. They also offer a snack option and 2 calorically dense high protein options. These do not contain the vitamin or sodium, so they are not complete nutrition. These would be, they're about 330 calories to 360 calories a pouch. But these would be good if you've got someone that just maybe needs like 1 meal supplemented a day, and then is via tube, and then is eating the rest of the time by mouth. I have had some patients or parents that request specifically this formula. It is the most thick, the highest viscosity one on the market, so it will not go through a pump. But then you have to add the vitamin. It's going to have to be a complete vitamin, which I will tell you all in a second, the ones that we use. And then you have to add salt in. It can actually be pretty dangerous if you have families that order these on their own and change. We've had 2 patients end up in PICU with hyponatremic seizures from families doing that. So when we send in the DME orders, our nurses know to look and see if they've been seen by a dietitian, evaluated, and they will not send it in if they haven't. So, and then Whole Story Meals is a little bit different than all the rest. It's a real food powdered meal. They have a plant or chicken based option, and they are 100 calories per scoop. So you can reconstitute it, make it more concentrated, make it less concentrated. They, up until really this year, they had just their original, a few different flavors, but just like the Real Food Blends, no added vitamin or salt, so kind of the same situation. Now they've come out with Plus, so they have an adult and a pediatric Plus version, which is complete and has everything added. And they have pediatric, adult, and renal options. So as you can see, there's, for families that want to feed real food, there are a lot of commercially available products on the market. So they don't have to take the time to blend themselves, as well as if they don't have access to a dietitian that can help them make their own recipes, then this might be a better option. So for safe preparation and administration, food safety and storage. So you're just going to need to follow the basic food safety guidelines for prep, storage, as well as sanitizing equipment. Families can blend each meal separately and feed immediately. So I have some families that want to blend up whatever their family's eating for dinner, and they'll push that right through the tube. They can also prepare 1 day's worth and then keep the unused portion in an airtight container in the refrigerator and use just within 3 to 4 days. So I will have some families, when we give the recipe, that will do that. They'll blend the night before, put it in a pitcher, mason jar, and feed off of that the following day. And then they can also prepare large batches and freeze. So I would say the large portion of patients I work with will spend a whole day blending, pears, broccoli, chicken, and they will freeze them in individual amounts and then have in the freezer bags like all the chicken, all the pears. And then that way they know for their recipe how many ounces of fruits, vegetables, meats, that sort of thing that they have to add. And it's a whole lot easier the night before, just night in the refrigerator day. So a lot of different ways to do this. And then if it's a commercially blenderized formula, then just follow the manufacturer's recommendations. Equipment needed. So a professional blender may be necessary if they're going to blend their own foods. But you can use infant purees as well. So a family that may not be able to get a Vitamix blender or a Blendtec, a really good blender, that may be a better option for them. Blendtec, Vitamix, and Viking are typically the blenders that we would recommend. If you're freezing, then you may need, after when you thaw it out, you may need to blend it again to get the smaller particle size. So if they're buying store-bought purees, then they can just use a wand blender to get it all mixed up once it's dumped in. So they would need enough refrigerator space to store, as well as freezer storage if they are going to blend in advance. These are soup cubes. You can get them in different sizes. So like half a cup sizes. Then you can get the ice cube trays that are like 1 ounce per cube. So again, like depending on what's going to be in the blend, those are great options. They can freeze and then dump them out into the freezer storage bag. Other equipment needed, so 60 ml syringes with a plunger. A small bore connector O-ring is going to be easier to push for the family. Some of these can be really, really thick. And depending on the age of the person administering it, it can be really difficult for them to push the plunger down. So large bore gravity bags and reusable bags. The Boley bags, which I did see somebody had on a table in the vendor's area, a Boley bag. You can use those with the large cap. Those are 375 ml bags. For those of you that didn't see, they're like a heavier plastic and they can be reused. For us in pediatrics, they are covered by insurance. So they can be reused up to 15 times. So, and then the Bowlink small cap attachment, I don't know that anybody, do you know if anybody had those? Okay, it's just a little small piece, but you'll see this picture right here. So they attach to the top of a baby food pouch, or like the Cape Farm blends is compatible. And then the other end attaches to the G-tube directly to the G-tube or to the connectivity kit. And you just squeeze it right in. So it eliminates the need for the 60 ml syringes, which can sometimes be difficult to get enough of them, and then the washing and all of that. And that, I can't remember how many times that little piece can be reused, but it's a whole lot easier cleanup than the syringes. So, and then a straight level extension set is going to allow for better flow, so less clogging. As far as delivery methods, so like I said before, bolus is going to be preferable, but they can be given through a pump. Usually if given via syringe, we tell the families 20 to 30 minutes for the whole feed to be administered. If they are going to be using gravity or a pump, then just keep in mind the hang time. So if it's homemade, 2 hours max. If it's really hot outside, it really should only be 1 hour. For the commercially blenderized feeds, it's just going to be based on the manufacturer's recommendations and the pump tests that they've done. Be aware that the pump is not always accurate with these. So I would say it's a pretty regular thing that families will keep the same rate. And then they come back and they'll call and say that there's still feed left over at the end. It's because it's going slower. The pump is having to work harder. We get a lot of pump burnout, which can be a problem getting another pump. So again, preferably bolus. There is the new Kangaroo Omni pump does have thicker tubing options that work great, but they are not that easy to obtain yet from home health care. I have probably 3 patients with that pump now, and they have had 0 issues with clogging, but they've been very difficult to obtain. So, and then there's really not an optimal consistency recommendation. So there's such a large variability between homemade and even batches of the commercially blended formulas. So I've had families that are on one product and then they get their next month's worth and there's chunks in it, which really shouldn't happen, but it does. And then we just tell them, put it back in the blender, blend it up more, and then feed it. So whenever we do a homemade blended feed, we tell families it should be the consistency of a stage 2 baby food. And that usually works the best. So you can use the IDSI test if there's a recommendation for a specific patient, pump, or product. And then you can use water, juice, milk, formula to thin it out as needed. And like I said, some of the homemade blends can be so thick, as well as like the real food blends that I mentioned can be so thick that families do have to add a little bit of liquid in order for them to be able to push the plunger down. So back to the pump, I usually now, because it's been such an issue, I always tell families the entire amount of the formula or the feed needs to be gone by the end of the feed. So you have to play with that rate a little bit. If they were on 45 an hour, we may tell them to push it up to 50 an hour to see if they get the full volume in 10 hours or whatever they were supposed to be receiving it in. So now creating the homemade blenderized tube feed. So start by building a meal plan. I always start with their estimated needs. What are they on? What have they been thriving on? And I try to match that. Looking at the DRI for protein, vitamins, and minerals, as well as fluid needs. Then I create my recipe using the ESHA research software. There are plenty of other chronometers is a great option as well, but you do need this software to evaluate the homemade recipe. So I always start by adding in the amounts of food groups. So I go back to the basics. How much, would their age typically eat? Fruits, vegetables, meats, grains, all of that. Add that in. Then I look at the macronutrient breakdown. So 45 to 65% of calories from carbs. And then the protein and the fat just based on their age or condition. Once I have that in, then I'm going to go through the different food groups now and kind of tell you how I do that. So with the milk group, you can use cow's milk, but a lot of families don't want to use cow's milk. So there's plenty of milk alternatives that can be used. You can use powdered milk to keep the volume down. I usually throw some yogurt in or a yogurt alternative for probiotics. And then in some cases where we really need a concentrated blend, then we'll use formula as the base if the family is okay with that. Sometimes they are, sometimes they are not. So you can use the commercially available blended products as a base as well. We've done that, or you can use just your standard, mineral formulas as the base. Then once we go to the fruits and vegetables, you can do frozen, canned, fresh, the infant purees. You can do a mix of them. Doesn't really matter. I do typically throw juice in to thin it out, unless I've got somebody on, let's just say, a FODMAP blended diet, then I wouldn't do it. So it's still case by case. I almost always throw in some leafy greens to get the vitamin K up. For the grains and starches, you can use a variety here: bread, oats, rice, quinoa, flours. If I need increased vitamins and minerals, then I'll use infant cereal, and I typically go with either oat or the multigrain cereals. I avoid rice because it's constipating, as well as the concern over arsenic if they're getting too much of it. For proteins, they can choose plant-based, animal-based, combination of both. Nut butters, beans, nuts, seeds. We use a lot of chia seeds, flax seeds. Infant meat purees, meat's not easy to puree, as well as eggs. And then for fat, liquid oils and MCT oil. So I do have families that ask about coconut oil and some other oils. And no, I would not recommend that when it is room temperature. If it hardens, you're going to have a problem long term. So nut butters and avocado also help us. If it's someone that has struggled with constipation, then we usually will recommend that they use flax oil for that. And then there's always a simple sugar source. So whether it's sugar, agave, maple syrup, honey, the juice, blackstrap, molasses, all of those can be used as the simple sugar source. So now I've got my recipe done, and I will compare to the estimated needs, tweak it from there, and then I go back and add the vitamin or salt as needed. So with the vitamins, there are only 2 on the market that I'm aware of that are going to meet 100% of nutrition needs for all vitamins and minerals. Often vitamin, so families have to understand that that may be an out-of-pocket expense. But the nano vitamin as well as the FlexiVits are going to be, if you follow the dose on the packaging, it's going to meet 100% of needs for the age, and they are divided up, or the nano is divided up by age. They are expensive, but we typically don't need the full dose. So I dose it down and it will last a lot longer than if they were giving the full, like 2 scoops a day or 4 scoops a day. Spectrum also is a powdered vitamin that is a little more complete than just something you would get over the counter. In some cases, you can get away with an over-the-counter vitamin. Probably an adult without volume restraints, that would probably work. But if they are going to be volume restricted, some of the kids that I've got are neuro kids and they're getting 300 calories a day and they're 8 years old. So we've got to have something more complete in those cases. For calcium, phos, and vitamin D, there are powdered options, liquid options, crushable options. We've used all of them. They all work. It's just your preference or the family's preference, really. So for salt, I go by the Aspen daily sodium requirements and vary between table salt, iodized salt, and light salt. So light salt I'm going to use if I need sodium and potassium, as well as iodine, and then iodized salt if I need iodine too. So, and then last but not least, look at the free water that the foods in the recipe are providing. Calculate the additional water needed outside of the recipe, and then recommend the flesh's water to thin it out as needed. In our food processor, so Isha, it oftentimes, I don't know why, but the juice does not populate under fluid. And sometimes even like some of the fruits and vegetables don't. So I would caution you to go back through and spot check everything to make sure that things are accounted for, and then manually add them in if necessary. I also will encourage parents to get a water bottle, whatever size. So if they need an extra 24 ounces a day of water, get a water bottle, mark it, and then fill that up every night and pull off of that during the day for flushes thinning, so that by the end of the day, they know it's all been given or how much is left to give. Because it's a lot to keep up with for these families. These are typically have a lot of medical issues. So this is an example of a final recipe that we would provide the family and then put in the patient chart. So if they're hospitalized, the other providers can see what their nutrition has been. But again, so you've got like your base at the top, your, in this case, yogurt, a little bit of juice. I always specify, the infant cereal, measure dry, the oil, flax oil for constipation. So I'll put tips out beside each component. If they want to, like, for example, the bread, calories in bread vary greatly. So I always put that out beside it. Or if I'd put oats, like steel cut oats, then I would say, or an alternative equal to 150 calories, whatever it is in the recipe. And then you've got your pureed fruits, vegetables, your protein sources, and the specific vitamin at the end. So the instructions below, and then the breakdown of the nutrition at the bottom. There are some good resources available. So this homemade blended formula handbook is great. This is going to be more for people that are wanting to change up what they feed every day. So it's broken up. They'll have different calorie levels in there, and it tells like how much from each food group. And then in the back of it, it even has like a list of the calorie levels for different foods. So I will use this if somebody doesn't want a recipe like I just showed you, they want to change it up. That's where I use this book, and I'll copy it and kind of go through and teach them how to come up with their own blends. The complete website is actually a great tool. I've had a few families that have used this to come up with their own blends. So you would provide whatever the goal is for them, and then they can go through and change it up, put in their fruits, their vegetables, their proteins, things like that. So it's actually a great tool. Choose My Plate, the complete tube feeding book, and then the Aspen consensus statement on blenderized tube feeds also has a pretty comprehensive list of resources as well. So Aspen practice recommendations that I did not go over, but I would want to include. So nutritional analysis is recommended with regular adjustments, PRN. I typically will follow up 1 month after I start someone on a homemade blended formula, make sure they're gaining, if they're or meeting whatever weight goal is. If I have to tweak it at all, then I'll follow up again at a month. But once I get them stable, meeting whatever goals, then I'll go to 3 months. If they're still doing well at that point, then I'll go to 6 months. So the younger the child, usually the closer I'm going to follow up because their needs are constantly changing. But the older kids that I work with, I usually, once they're stable, could go to 6 months and sometimes even a year with those families. They can use the same recipe daily or vary it so long as it meets the patient's needs. Modulars can be used to meet needs, but are not always necessary. I would say it's pretty rare that I need to pull in like sole carb or do a cow, anything like that. So fluid needs should be met, and fluid from recipe should be taken into account. But use caution when adding it to the recipe because it's going to dilute that. As well as if you're using it to treat GI symptoms, the more fluid you add, the less it's going to help with that. So remember, the gravity and how heavy it is really one of the things that helps with the vomiting, the retching, the gagging that we see. There are hospital considerations that are included in the recommendations if any of y'all are inpatient and want to start using these. Follow up with a dietitian or nutrition support specialist knowledgeable in blenderized tube feeds is essential. So it's recommended to follow up every 1 to 2 months initially, and then you can move to every 4 to 6 months as the patient is stable. And like I said, I've got some older patients that I see once a year. So, and then lab parameters should be monitored based on nutrition assessment and individual signs or symptoms of deficiencies. So the key takeaways are that blenderized tube feeds are safe and effective. RDs should be willing to learn and assist families with blenderized tube feeds. This I thought was a pretty powerful quote from the Bennett paper. I felt angry after working with 2 RDNs. I felt that working with a dietitian was not worth my time. A parent is trying to do their very best. There's research supporting blended feeds, and many people do them on their own. Just look at social media. So I think we're doing a disservice to our patients not to learn about these and not to offer them as an option. There are a variety of considerations when deciding if a patient is a good candidate, as well as whether homemade or commercially blended formulas are a better option, as well as patients on blenderized feeds should be closely monitored by a dietitian familiar with blenderized feeds who has the ability to analyze recipes. Okay. I have 3 evaluation questions. So do you want me to go through these or? Okay. Yeah, we've got like 3 minutes, I think, left. So, which of the following is not a commonly cited reason families choose blenderized tube feeding over commercial formulas? A, improved tolerance. B, desire to provide real food ingredients. C, elimination of all feeding tubes. Or D, increased caregiver control and involvement in nutrition. Yay, good. Which patient would be the best candidate for a blenderized tube feeding regimen? A patient with frequent hospitalizations and no caregiver support at home, a medically stable patient with a gastrostomy tube, motivated caregivers, and an adequate blender access, a newly post-op patient with high volume jejunal feeds and feeding intolerance, or D, a patient receiving continuous jejunal feeds who requires a sterile diet due to neutropenia. Good job. I know these were hard. When preparing a homemade blenderized tube feeding, which of the following is essential to ensure both safety and nutritional adequacy? Limiting variety to only 3 ingredients, avoiding the use of commercial blenders, collaborating with the registered dietitian to assess macro and micronutrient needs, or preparing large batches to store at room temperature. Good job. Okay. And then I've got my references here. And any questions?
Hi, thank you for a wonderful presentation. At the annual Aspen conference, RDs who presented on blenderized tube feeds had mentioned about the use of AI to generate patient-specific recipes. Can you comment on that, please?
I have never done that. I can tell you it would make me a little nervous. But I can also see where it might be a tool and time saver, because when we create a recipe, I mean, at that initial appointment, I'm really evaluating, are they a good candidate, and going through showing them what this is going to look like, what it's going to entail. And then I ask them to give me a week to come up with a recipe. And I email it to them and then follow up from there. So when we actually make the recipe, it's a good, I mean, I do them all the time, so it takes me a good 30 minutes, and I do them regularly. I can see where if you do use AI and put in exactly what you're looking for, it may save some time, but I would say that you need to double check it yourself, put it in your whatever your software is, and then go from there. But I mean, you know, I need to try that actually and see how much time it saves me and how accurate it actually ends up being. Yeah, it's interesting. AI is going to take all of our jobs.
Allison, were there any questions online?
Okay, there is one question. Okay. Assuming you work with just the peds population, do you know of any RDs doing this with the adult population locally that we can refer out to as well?
So, my practice, we actually do take a few adult patients for very specific things. And I would say this is one of them, because it's not easy to find somebody that can do them. And frankly, there's not, I mean, other than the difference in needs, there's really not, there's no difference in creating the recipe. I do know, I believe there was someone at, I think she's at Piedmont, maybe in the ALS clinic, that uses these on occasion. Yeah. But I don't know of any other adult RDs that are doing them regularly. So yeah. And I mean, it's very difficult to transition our peds patients into adult care, like our chronic kids that have G tubes. I mean, it always surprises me. Like there's there's not a lot of outpatient resources, and even like transitioning to the adult GI doctors, like my patients have the hardest time finding one that is familiar with a G tube. And then if they have problems with formula, they don't know much about changing formula or what to do. So we get calls quite a bit from adult GI practices about adult patients, and we usually see them ourselves. And then our patients that age out that are, 100% tube fed, we keep them. So just because, and then we work with the adult GI doctor that they transition to. But that's a big reason why. So.
Thank you, Bailey. No other online.
So you mentioned you will follow them if they age out into adulthood. Obviously, I guess you reevaluate the recipes, and what
Yeah.
kind of changes do you typically?
So usually once they're, there's two things. One would be if they've been on formula, we're typically involved if they're enterally fed. If they have a feeding tube, we're usually involved. And I start telling my patients around the age of 19 that they need to start looking into what they're going to do when this child turns 21, because their formula will not be covered. That gives the parents about 2 years to look at waivers and to figure things out. And it takes that long. So if they've looked into it, they don't have access, then we'll transition them, and it would be kind of the same process, looking at what have they been stable on. That's what we're going to do. Those are going to be our goals, and then follow up a month later, make sure that everything is still stable. But from a vitamin and mineral standpoint, their needs aren't really changing that much at that point. We're not looking for growth. So those would be patients, once I see that whatever recipe we're coming up with, I would, do the 1 month, usually 3 months, 6 months, and then yearly after that. So, and I've got a 30-year-old that I still see yearly. So, and nothing's really changing with her. So, yeah. And really even like 17, like the younger kids, like they're, once they're stable, their needs aren't changing that much. So an adult would be, very similar once you get them on that blend. So.
I have another question. So obviously blenderized tube feeds itself is kind of a market trend, I guess, if you will. You're getting more patients that are asking for it. Are there any other things as you're creating recipes that you see patients asking for? Any kind of trends that you see? Anybody looking to add any specific foods or supplements or anything like that?
A lot of the families that we work with do want to provide extra supplements, or I would say, like Himalayan pink salt, like things like that. They are very specific about certain ingredients that they want to use. That doesn't, it shouldn't make that much of a difference, but, as long as it's safe, and as long as whatever, like if I'm adding salt into a formula, I need to make sure that whatever equivalent is going to provide what I need it to provide. And if it doesn't, then that's what I'll tell the family. So again, it kind of goes back to, they need to be a family that's typically going to listen and follow recommendations. But usually when you tell them the reason why this needs to happen a certain way, then they are usually on board with that. So, and there have been families that did not follow up like they were supposed to, and we will not continue to write orders for, if they're using formula as a base, or, we will hold those orders to get them back in. Doesn't happen that often, but they have to be seen. So.
Kind of follow up on hers, like, do you get pushback from the simple sugar aspect of it?
Sometimes, yeah. And I will tell you, like, I don't usually, like, personally, I don't add table sugar into my blends usually. I'm usually going to choose something like, I'm going to look at like the juice to thin it out and getting sugar that way. for whatever, I mean, well, y'all know agave, everybody thinks that's better than, every other sugar. So depending on the family, sometimes I'll do that, or maple syrup. Honey, I use a lot because families typically don't give me pushback about honey. So I use a variety, but I usually try to stay away from table sugar because I just don't want to go there with families. And it's not a lot that we have to add. And again, if you explain to them, why, then usually they're okay with it. But I prefer just not to have that conversation and choose an alternative. My FODMAP ones, we would obviously not use honey. We would go with maple syrup.
Any other questions?
Okay, wonderful. Thank you so much. I feel like a 90s talk show host walking down here. Thank you.
Yeah, and I'm happy. My email's up there. So if any of y'all are, want to start doing this in your practice and you have questions, then I definitely would be happy to answer any questions.
Wonderful. Thank you